So, okay, yeah, let me just press OK on that. Good. So, again, like Tim said, my name is John Doolan. I am a podiatrist in Manhattan. I have been in private practice and a university-based setting now for about 25 years. I have a lot of experience with skin graft substitutes. Basically, everyone that's on the market, I have used and applied. And the other thing is knowing the logistics about it. I'm not going to go into the science so much of any of these things. If you have a quick question, I'll be happy to answer it. But the science is a separate topic, and we could talk about it. But today, I'd like to really talk about the logistics of getting it from from the company onto the patient and getting paid for it, and not getting audited. And if you do get audited, not having to give any money. And there's a lot of steps in between that process that need to occur. So again, I run and I'm a co-founder of a limb preservation center in Manhattan. It's called PALP, the Program for Advanced Limb Preservation. It's at Cornell. And I see a ton of diabetic foot wounds and venous leg ulcers. The good thing about amniotic membranes is we could use them on both of those type of wounds as well as other types, basically almost any type of wound. So we'll go over that a little bit too. Tim, are we waiting on anyone in particular that we want to wait on, or you have to just unmute because I couldn't hear you?
Yeah, no, I think we're good. We're
okay.
Good to go.
We got our main crew here.
We've got 35 people in right now, so we're good.
Great.
Yeah.
Okay, so I'm going to go to the next slide, and basically I'm just going to keep hitting bullet points of the most important thing. I'm assuming, Tim, but you could tell me, is most of the people on here, are we talking about representatives for the company that are carrying the graft?
Yeah, the distributors. Yeah. So
okay, good.
This is good for them because they're going to be better resources to their customers, and they're going to have a better understanding of what challenges you guys face as the providers.
Absolutely.
For getting paid and documentation and medical necessity and all those things.
The last thing we want for our doctors or our facilities is to put these on, get good results, and not get paid. It's going to cause a problem with business, and it's going to cause a problem with the doctor's income and finances, because we have to pay for these things before we put them on. So I'm just going to talk a little bit, skin graft substitutes. They're very important in helping us heal wounds. We know that, and they could speed things up quite a bit. So there's different types of skin graft substitutes. Allografts are from other humans. Xenografts are from animals. There's synthetic grafts out there, and then there's basically amniotic membranes. I consider a little bit different, and we're going to talk about the classification a little bit. I think this is just important. Just as being a representative, you have to know what you're carrying. So there's 3 FDA regulatory classifications for these grafts. You've got a class 3 PMA. Really, the only one in that class is like Apligraf. That's a bioengineered product. It had to go through extensive FDA trials, randomized clinical trials. And because of that, it has an indication. Its indications are to treat venous leg ulcers and diabetic foot ulcers. That's great, and it makes
Good job, dude.
What is it, Tim?
Yeah.
What?
Hey guys, whoever doesn't have their phone muted, please mute your phone for us.
Oh yeah, if we could all mute the phone, that would be great, or mute your computer or phone. So I was just talking about the class 3 PMA, just to give you a little education on it, because this is what you're going to be going against. The good part about having these robust FDA studies is it's got a lot of data, and because it has a lot of data, it got a lot of approvals for commercial insurances. The bad part is you have to have a diabetic foot ulcer or a venous leg ulcer to use this product, and if you don't, you're not allowed to use it. So you can't use it on an arterial ulcer, a wound dehiscence, a burn, a surgical complication wound. So, but it's important to know the classification of it. And then you got your class 2 510Ks. That's your, like, this is just two examples, Primatric and Puriply. These are examples of actually xenografts that are basically considered safe, and they don't really have to show that they do anything. They're just considered safe. And then we have a long history of using them. Then there's your human cell and tissue products. They fall under a category called 361 HCP/T. Those are human products that are used for analogous use. This is where our graft falls into place here. Basically, our graft that we're talking about here, the two grafts that Revigen carries that I'm aware of are Amnio Armor and RevaShield. They're amniotic membranes, and we have to, quote unquote, use them for analogous use. We're using them as a wound care barrier or covering. And they contain, and in this case, they contain a whole milieu of growth factors, maybe over 100 growth factors. So we're adding growth factors onto wounds that are either stalled or granular to get them to heal faster. And this is our sweet spot. We could put this on any kind of wound, but we do need the documentation for it, and I want to go over that. So that's a little overview on the classification of the types of grafts that are out there. Just going to stop for a second. Everyone with us so far, if there's any questions, kind of raise your hand or hit a chat. All right, I'm going to move on here. So the clinical applications are for basically all kinds of wounds. These are just different types. And again, the advantages of using this over a split thickness skin graft is you don't have to take it from the patient's thigh or waist or butt. And that's good for a couple of reasons. One, that's a big procedure. Two, that leaves another wound on them. And these patients aren't healthy. These aren't like 26-year-old athletes that if you put a wound on their leg, they're going to heal that. These are patients who are sick. They have wounds on their leg. And we don't want to give them another wound, especially if it's not going to take. So there's a lot of advantages to doing this and very few disadvantages other than making sure we get reimbursed and these things get paid for. So there's a lot of challenges to getting paid and billing correctly. And the stakeholders are everyone on this call right now, the physicians, the patients, the coders, the billers, and the insurance companies. We all got to be involved in this to make this a successful venture for our doctors or facilities. Otherwise, it's not going to work. So here is when we start going to hit some of the really good take-home messages. So everyone that's in this business, let's get ready here. Whenever I use a skin graft, I want to have two ICD-10 codes. One explaining the etiology of the wound. The next one explaining the location. For example, a diabetic foot ulcer, E11621. That's your ICD-9 diagnosis code. That's a diabetes with ulcer. The location, L97519. That's your right foot. There's obviously more than one example of this, but my point is, one, we're telling you what kind of wound it is, and two, I'm telling you where it is. Another example, I83.003, venous leg ulcer. Where? L97309, ankle. Another example would be PAD, peripheral arterial disease. There's an ICD-10 code for that. So the take-home message, and this is one of the most important slides, there's going to be about 5 that I'm going to say that on, but this is it. 2 diagnosis codes for every wound. First one being the etiology, the second one being the location. I know I'm beating it up because it's important. Okay, now we're going to go to the next important thing, the CPT code. The CPT is the surgeon's application code. The 2 big workhorses of this one are 15271 and 15275. They're explaining themselves there. And 15276 is if you go over the first 25 square centimeters. One important thing about this, one, you cannot bill these codes unless you're putting on a skin graft substitute. Otherwise, you have to bill for a debridement code, which is 11042 or 43 or 44, whatever you're debriding. These codes pay well. In my jurisdiction, they pay about $200. That varies from area to area across the country. But that is a nice little bonus on top of the Q code that we'll talk about in a second, but this is an application of skin graft substitute. It needs a right or left modifier when applied to the lower extremity. Again, when your doctors ask how much this reimburses, and this is also part of the, I don't want to say your pitch, this is just explaining to the doctor that this is part of their billing. One, you need to bill it, and two, you get paid very nicely on it. One thing I forgot to put in, but I just thought of it, there's another code, 15004. That is the prep of wound bed, and that should be billed the week before you apply the graft. I like to do that on the first visit, provided that if they meet all the requirements. Again, that's 15004. And that's preparation of wound bed with the anticipation that you'll be grafting it the next week. That also pays very nicely. We're not trying to sell our doctors this. We're not trying to make this a business, but it is a business. And the doctors need to get reimbursed. They need to know what they're allowed to bill, and they need to know how to get paid so this could continue so they can get the patients better. So these are the CPT codes. Now, if you're putting on an Uniboot or Pro4, that's an additional code. I could get you the codes if you need them, but I'm just giving you an example of when we apply a graft, this is for any graft of a skin graft substitute, this code needs to be put with a right or left modifier. Again, 15004 the week before, preparation of wound bed in anticipation of skin graft for the following week. Okay. So right now we got the ICD-10, I'm sorry. That's our diagnosis codes. Then we got our procedure codes. Now we got to get paid for the actual graft. This is our Q codes. They call it HCPCS or HCPCS codes. So for amnio armor, it's Q4188, and you must have the amount of units you apply. If you just put Q4188 in your bill and you send it away to Medicare, you will get paid for 1 unit. You will lose money if you're the doctor because you put on a piece of graft that's 2 centimeters by 3, which is 6. So you have to put in 6 units. Then you get your full amount back. Revishield Q4289, same thing. 2 units, 5 units, 6 units, whatever, not whatever you use, whatever size the graft is. So if the graft comes in a 6-unit size, you bill for that. Even if you didn't use all 6 units, then you'll document what was wasted with a JW modifier. JW is the amount wasted. You still get paid for the full amount. So if you purchase a 6-unit graft and you applied any portion of that 6-unit graft, you get paid for the full amount. For some reason, Medicare just wants to know if any was wasted and how much. I usually don't waste much of this. I'd rather double it up and use the whole thing. This way, there's no issue. But when I do document it. You get paid the full amount. I can't tell you how many times a doctor friend of mine or my colleagues bill everything correctly except the units. And you get paid 1/6, 1/10, 1/25, the amount of your payment because you didn't put the right amount of units in. Medicare is not going to remind you to bill that amount of units. You must do that on your own. So you got to tell the doctor, make sure you put the right amount of units in. And it's always the size of the graft. And it's pretty self-explanatory. It's how many square centimeters the graft is, not the wound, the graft. Okay, so that's the billing in a nutshell. I want to go over the documentation, but before we do that, everyone following so far, any questions or concerns or comments? I'm happy to hear any other comments on this too. Tim, I don't know if you want to take a little survey of the room. I don't have everyone on the screen right now. Everyone good?
Yeah, anybody that wants to ask a question, just
Is there a J code for waste? I got in the questions. I like that question. It's a JW modifier. I'd like to put it in my note, which I'll show you in a minute. And it's a modifier. Not all Medicare carriers require this, but I like to do it anyway. I got a question, Dr. Doolan, in regards to application of the products cleared down to bone. There are no contraindications or indications. I will tell you things don't usually heal well over bone. So you need to debride and get good bleeding bone before you put one on if you want to be a good doctor and have an effective graft. But there's no product that's indicated to go over bone. However, there's not a contraindication or a disallowing of the graft if you're putting it over bone. So to the answer to the question is, yes, you can put this over bone. I recommend you debride that bone down to bleeding for the application if you're going to do it, so you get a good result. All right, we're going to go on to the next area, which is probably the most important thing. This part that we spoke about already is obviously how we're getting paid, and we need to do that. We can't lose money as a business, and we can't pay to get our patients to get better. So we need to let Medicare or whoever's reading these notes, and it's mostly going to be Medicare, that we did the right thing at the right time. So we have to document necessity and detail prescription, the type of graft we're using. And I'm going to go over some things. I'm going to go over my typical template, which I could get to anyone here so they could get it to their doctors so they don't have any issues. This is a pre-treatment for amnio-ulnar. I'm just giving you a classic example. So we do the pre-treatment, today's time and date. You don't need the time, but the date's nice. You want to show that the ulcer has been present for however long it's been present. Some carriers let you do an ulcer right away. Some are up to 12 weeks. Some are 6 weeks. That doesn't mean you have to been treating them for that long. They just have to come to your office and you have to document patient has a wound for 2 months and had such and such a treatment, had wet to dry, had a debridement, had Santal, had whatever they had, as long as it's in your notes, and that they had standard of care or conservative treatment for the last X amount of weeks. If you just don't have that anywhere, patient presents to your office with a wound, Medicare doesn't know that this wound was caused yesterday by a blister, and they don't want that wound. They want a wound that showed not to heal, and we need to use something else to get it there. So you want to write in the ulcer has failed to improve or remains the same size. The treatment for their underlying cause, let's say diabetes, is been monitored and we're on it. You don't want to do this on a diabetic patient whose hemoglobin A1C is 13. If they're not having their diabetes managed appropriately and you documenting it, you are risking not applying this graft in an appropriate manner. So you want to document that their hemoglobin A1C is either well controlled or under 8, that their diabetes is being managed by an appropriate provider. I think we got another question, so okay, we're going to go on a little more here. Thank you, by the way. So this is the first part, okay? Wound assessment. You should have a measurement of the wound every visit. There are no exceptions to that statement. I want width, length, width, and depth. 3 measurements every time. I think it's appropriate to have a picture every visit. You're saving yourself by doing this. You're justifying your application by doing this. So every note, every visit, you need to have a measurement. You don't need to have a picture, but I'd like you to have a picture. If you don't have a picture, it's okay if you have a measurement. Let's go now to this other requirements here. You're describing the wound. You're describing your debridement. Every wound should be sharp debrided with a 15 blade every visit before every application. If a surgeon is not doing that, I know you're not going to interfere and tell them they need to do that, but you could suggest all the literature shows this heals better when debrided down to bleeding tissue each application. You're doing that for many reasons. One, to clear the biofilm and bioburden. You don't want to put this on a fibrotic wound or wound that's draining. Otherwise, you're putting it on top of a scaffold that has bacteria on it and slough. That is not going to take well. It's not going to work well. The optimum time to put this on is after sharp debridement when it's bleeding. Ankle brachial index. If they have palpable pulses, you don't have to have an ankle brachial index, which is called an ABI. That's a non-invasive vascular study. but you better document that they have palpable pulses. You don't want to have no documentation in your chart that you never checked their circulation, or that their circulation had a 0.6 or non-palpable pulses. Medicare is going to go, why are you putting this on a person with no flow? If they already went to their doctor and they got an angioplasty or stent or a bypass, document that. Has had an intervention and cleared by vascular, or now has a ABI of 0.6 or 0.8 or 0.9, whatever it is. If it's 0.4 or 0.5, don't graft this person. They're not going to do well. You're going to be wasting your time. You're going to be wasting money, and Medicare will go, why did you do that? You do more than one or two, they're going to ask for their money back. Okay, diagnosis. We know that. Diabetes, we talked about this already. By the way, not only your diagnosis code's going to be in your billing form, they better be in your note. Patient with diabetic foot, also right foot on the heel. Here's the measurements. Here's the picture. That's all got to be in your note, not just your billing. Continue. This is initial application of amnio armor. The second one, this will be a reapplication of amnio armor. The wound site was washed with normal saline and debrided with a curette or 15 blade. Always document that the graft was fixated with steri-strips. If you're gonna fixate with something else, that's fine. I never fixate it with suture or staples unless I'm in the OR and not with amnio armor. But always, you must document how it was fixated. Steri-strips is very appropriate. The wound dressing includes adaptic gauze, Coban, and a compression. The patient is going to be non-weight bearing or wearing a surgical shoe or a compression dressing. We got to do all this. And then finally at the end, that's where the JW wastage comes in there and the amount used. That's my note. That's not the billing. The billing we went over already. That's my note. It's in every note. Of course, you could just copy and paste this and change the measurements for the next note. And if you have any wastage, or you document it. This has to be done on every note. Everyone's probably going, wow, that's a lot. It's not a lot when you copy and paste and click it the next time. It's a lot the first time. That's it. Every other time, you're just documenting the progress. On that, let's say your first wound is measuring 3 centimeters by 3 centimeters, and your next 5 measurements are 3 centimeters by 3 centimeters. You better stop putting that graft on. You can't have no improvement in your documentation. Keep using grafts and think Medicare is going to keep paying you. You will get audited and you will give back probably 2 or 3 of those. If you have 4 consecutive visits with no progress, either in the presentation of the wound or the measurements, you missed something. Do something else. Recheck their circulation. Check to see if they have an underlying infection. Check to see if their sugar's under control. Something's wrong. You can't just keep putting a graft on and go forever. Well, it didn't get any smaller. I'll try it again next week. The definition of insanity. Keep doing the same thing, expect a different result. Medicare doesn't like insanity. They will audit you. You will give back all the money. You'll blame everyone else but yourself. It's your own fault as the doctor. I'm speaking to the doctor here, not to the reps. You must have progress or document why you don't think you have progress before using this graft again. Common coding errors. We went over the most common one. You didn't put the units. If you don't put the units, don't expect to get paid for the amount of units you put on. If you didn't use both diagnosis codes, you might get denied. Your CPT code. Believe it or not, if you don't put down application of skin graft substitute, even if you put down the Q code, they're not going to pay you. They want to see that you did everything, and then you actually get paid even more. So make sure you put on everything. You don't bill for a debridement these days during the application days. You can't. You're not allowed to. You don't bill for an office visit unless you are doing something else. But don't bill a 99213 the day they come in and all you did was put on a graft. That's not allowed. You'll cause delays in your payments. And you didn't do a 99213. So don't bill it. Again, I'm speaking to everyone as if they were the doctor. But these are the messages you have to get across to your providers, to the facilities, to make sure that they don't get burned. We have to have each other's back here. Otherwise, no one's going to do well. Um, Tim, I gave you an example of some of certain carriers' requisites. They do vary from carrier to carrier, but essentially that template covers all of them.
Yeah, that should cover all the Macs.
Exactly.
Yeah.
I know I went over a lot in a short period of time, and I'm very straightforward and not flexible on a lot of this stuff because it needs to be there.
Hey, John,
yeah.
would you be willing to share the slide presentation with me so that the reps that need it to need a refresher can we get a copy of just those slides with those key points, those 4 key?
Absolutely. I will
Okay.
email it to you later tonight.
Okay.
Yeah, that's not a problem at all. Also, the template, I emailed it to Tim separately. Feel free to copy and paste it and slightly alter it. I gave you an actual marked up version of my template, but in other words, I wrote in has an ABI of 0.65. You could write in has palpable pulses on examination or Dopplerable pulses on examination. Those are fine, but you can't have in your note no vascular exam or non-palpable pulses and expect to get paid and not get audited. I've seen audits. I've passed audits. I've had other patient doctors fail audits where they did everything right except for document and they got nailed. They had to give back the money. Let's not have that be any of our doctors. Do you have an antimicrobial resistant test completed before application? No. Very good question. I don't culture wounds that are not infected. If the wound is infected, that's the only time I'll culture them. Culturing a wound that's not infected is going to get you chasing, chasing things. You're going to grow MRSA and Pseudomonas and all kinds of things. Hold on one moment. I'm just getting a phone call from my doorman. Hello? Okay, thanks. I'm sorry about that. So you have to only swab or culture infected wounds. If you swab or culture a non-infected wound, you're going to be chasing bugs for no good reason. So and there are no requirements that you have to do that before application. Do you still apply 10 grafts if needed? If you had to skip a week or two due to infection, how important is this stay within a 12-week period? So each graft will have a certain amount of applications it is allowed. Some grafts are allowed to have an indefinite amount of applications as long as you show progression. So but we do have some graft that, let's say, have a 10 graft or 12 graft limit. I don't ever skip, if it's infected, we don't apply, obviously. But sometimes I'll skip a week if we have a limited amount of applications. Obviously, debride them, change their dressing, or maybe start them on Santal or something else while we're buying time. But if again, we'll go back to documentation. If you document progression, the carrier will usually allow you to continue grafting. If you're documenting a stalling wound, they're gonna say you're done. So a very good question. Any other questions? Feel free to put it in the chat.
Yeah, this is great, Dr. Doolan. We appreciate it. And we'll field the follow-up questions. Oh, here we go. Here comes some more.
Yeah, and my experience with audits has come up about informed consent. No, it's almost implied, the informed consent. Of course, informed consent comes up with legal cases, not so much with audits. It's very rare that a patient is not on board with the fact that you're grafting them every week. So that's another very good question. It's more pertinent to surgical procedures than to application of grafts. And that's more of a legal issue with the patient, not with the audit. But again, very good question. These are all good questions. By the way, these are the questions that doctors ask. They don't know. You now know more than 99.9% of doctors when it comes to coding and billing of this. Keep asking these questions. Ask about what are their questions, then bring them to me or bring them to Tim. I will help you answer them. This is like when I give these lectures, these are the questions people ask me. So don't feel shy. These are great questions. I am going to email Tim my whole slide presentation here. It's not so in depth, but I'm happy to share it. And please bring on the questions. Tim will get them to me. I'll get you answers. If I don't know the answer, I'll get it.
You guys, we appreciate you guys taking time out of your busy schedules to hop on this. We hope you found it valuable. And we look forward to following up with you on any additional questions, but this will help you guys really serve your customers and be a good resource. And I think it's very important for all of us to have this kind of resource for the physicians that we're working with. So thanks for taking time to learn it.
Thank you, Tim. I'll get that email to you. Take care.
Thank you, John. Appreciate you.
Okay.
Thanks.
Thanks, everybody. Appreciate it.